What's up guys, it's step 0 and today I want to cover ACLS because I just did the ACLS exam from the American Heart Association. I'm going to tell you a little bit about it. We'll go over this through some rapid review and hopefully it'll help you get prepared for your test. So here's a breakdown of how the test is like. I had the first time ACLS course, so my course was broken up into 2 days. I know there's also one-day courses. On the first day we just did basic review, watched some videos, and on the second day we did the testing. So during the test you have a certain number of scenarios. Usually the examiners have about 6 random testing scenarios that they'll throw at you, and these are multi-part scenarios. Usually they'll give you a case, they'll read out a patient description, then you'll have the mannequin on the desk to work on. First thing you want to do, O2, IV, and hook them up to the monitor. Then you'll get a rhythm, and the rhythm will tell you kind of how to proceed. And also, if they don't have a pulse, make sure you start CPR immediately. The rhythm usually starts out as either Brady or Tachy, will progress to VFIB, pulses VTACH, or PA Asystole, and each time the rhythm changes after your 2 minutes of CPR is done, you adjust and treat down the new algorithm. Sometimes you'll start off in VTACH, and that can be a little tricky for some people. And after the scenarios, you have 50 multiple choice questions to complete that you need an 83% on or more to pass. And don't worry, these questions are not hard. The vignettes are very straightforward and the answer choices are short. So they give you an hour to do it, and I think maybe half an hour is enough. For all the cases, just remember these 3 things in the beginning. It's very easy to freeze up when you're put on the spot as the team leader. And if you just get in the rhythm of, saying, O2, I need you to do IV lines and I need you to hook them up to the monitor and place the pads on, then you'll kind of calm down and ease into the simulation. Don't get stressed out. Take a pause if you need to, and just make sure you're saying the right things. Also remember, some patients might be a little young, teenage age. If you're suspecting they might have OD'd, give them naloxone and make sure to ask for it when you get the AED. Airway management. There's a couple key things to know about the airway and the ventilation. So there's 2 advanced airways, the nasopharyngeal and the oropharyngeal. Nasopharyngeal is for conscious people that have a gag reflex, and you measure that from the nose to the earlobe. And oropharyngeal is for unconscious people who with no gag reflex, and you measure that from the mouth to the angle of the jaw to make sure it's appropriately sized. Make sure you know how to measure these airways because that's something that's commonly tested. Ventilation, so this is another thing that's commonly tested. You want to give 1 breath every 6 seconds. The breath is given over 1 second, and you use only half the bag, so you don't squeeze that bag fully. And the reason for this is because if you overventilate them, you'll increase intrathoracic tension, and this will decrease venous return to the heart and therefore decrease cardiac output. If the lungs are pressing on the IVC, on the SVC, you're going to get less return to the heart. So just remember the decrease in cardiac output if you overventilate. You can also cause things like barotrauma, but cardiac output is very much tested. Then remember, after you've achieved ROSC in the patient, you want to do a primary survey, ABC, again. And for the airway, if they're not breathing properly, you want to intubate them. That's going to be a point on the simulation. So remember, after ROSC, ABCs, intubate if needed. Bradycardia. So let's talk about the rhythms that have a pulse, and then we'll talk about the rhythms that don't have a pulse. So let's cover bradycardia. Now this is going to include your sinus brady and your heart blocks, and you can divide it really into 2 sections, stable and unstable. Okay, stable, you just monitor, pretty much do nothing, and then unstable, you are the really tested ones. So atropine here is the drug to look out for. You have 1 milligram of atropine every 3 to 5 minutes for a maximum of 3 doses. Alright, so you can give atropine for sinus brady, you can give it for 1st degree heart block and 2nd degree type 1 or Winkenbach. You cannot give it for 2nd degree type 2 or for 3rd degree. So watch out for those, because for those you want to skip right down to the second line treatment, which is transcutaneous pacing. Okay, so atropine, then transcutaneous pacing. For a lot of the cases, they really love third degree heart block, so you're just going to skip right to transcutaneous pacing. And then remember, for pacing, if you have a narcotic or a benzo available to you, give that first. But if it's not rapidly available, you don't need it. And also, you can add an adjunct of dopamine once it becomes available. But usually pacing in the situations will be kind of your go-to. Some key facts. You want to pace them at a rate of around 60. Most of the instructors like 60. It can be 60 to 80 in the textbook, but you want to pace them at the bare minimum, which is 60 beats per minute. And also, second line drugs. If you, let's say for example, you can't pace them, or pacing is not enough, you can add epi or dopamine to help them out. You have 2 to 10 micrograms per kilogram of epi, or 5 to 20 micrograms per kilogram of dopamine, which can be added as second line. And for example, if all that doesn't work, you can get an expert consult and do transvenous pacing, which is going to require someone who knows what they're doing to put that in there. So we've covered bradycardia. This is low heart rate with a pulse, usually 50 or less in most cases, that you'll be presented with. Now let's cover another pulse emergency with a pulse. It's going to be tachycardia, where their pulse is going to be 150 plus. Now, they'll either be stable or unstable. So if it's unstable, it'll usually be 150 plus, and if it's stable, it'll be somewhere 100 to 150. Now, stable tachycardia and unstable are differentiated by things like hypotension, chest discomfort, shock, heart failure. So if anything seems kind of off, usually watch out for the hypotension. That, even in bradycardia, will differentiate your stable from unstable. Okay, and if they're unstable, you want to cardiovert them, and then the drug here is adenosine. So stable, let's start talking about stable before we get out of hand here. Stable requires first line treatments as vagal maneuvers. You want to ask the patient to bear down, but be careful to ask them not to poop themselves, because it happens. So vagal maneuvers and bearing down is your first line for a stable tachy. Then you can give adenosine. Now adenosine is a 6 milligram dose. Then you wait, you flush with 12 milligrams of saline, and then you can give 12 milligrams later. So it's 6, then 12, then stop. Some special cases which you won't be tested on is that you give 3 milligrams if the person's on dipyridamole or carbamazepine, which is a seizure drug, and you do not give in asthma or COPD because it can cause bronchospasm. Beta blockers and calcium channel blockers are next in line, and they're usually first line for AFib flutter. So let's say you botched the rhythm analysis, you didn't see the AFib flutter, you saw the stable tachy, you gave adenosine. Didn't help, you give calcium channel beta blocker, and then that calms it down. Usually that'll help a lot for AFib flutter. If you see AFib flutter outright, you just want to jump to the calcium channel blocker, beta blocker. Don't worry about the adenosine. Wide complex. So we covered narrow complex rhythms with our vagal maneuvers, adenosine, calcium channel. Now let's cover wide complex maneuvers with adenosine and antiarrhythmics. So wide complex, stable, right? They don't have hypotension, they don't have chest discomfort, they're just sitting there. You can give adenosine if it's monomorphic. Usually the instructors will be kind of iffy on that, so watch out, because they might just recommend you go to the second line, which is one of the antiarrhythmics, also known as procainamide, amiodarone, and sotalol. Now you'll see amiodarone again in the pulseless algorithm for VTACH, VFIB, all those. So the amiodarone here is 150 over 10 minutes. Remember that the amiodarone in the other algorithm is going to be 300, then 150. Here, for tachycardia, wide complex, second line, amiodarone 150. Now, are big cream and cheese. Mostly they'll test you on unstable rhythms. I'm like over 80% of the time. So unstable tachycardia. What do you want to do? So they have hypotension, tachycardia. They have chest discomfort, tachycardia. You want to cardiovert. And before cardioverting, just like pacing, you want to give them something. So sedate if available. You never cardiovert sinus tach, okay? And even if it's unstable. And adenosine is used if it's narrow complex. So if you're unstable and you have a narrow complex tachycardia, you give adenosine 6 then 12, then stop. And then for second line, you can give procainamide, amiodarone, and sotalol, the antiarrhythmics that we discussed, with stable wide complex. Okay, so first line for tachy, adenosine. Second line, procainamide, amiodarone, and sotalol. If they're unstable, you want to get them shocked, so cardiovert them. This is also known as synchronized cardioversion. Unsynchronized cardioversion is for pulseless people. Let's go through a scenario where the person has no pulse, they're in cardiac arrest, and they have a VFIB or pulseless VTACH on the monitor. So you hook them up to the monitor, you see VFIB or pulseless VTACH, you want to start CPR immediately, give oxygen, get IV access. Then you want to shock as soon as possible. This is important here. The first thing you do for VFIB and pulseless VTACH is shock as soon as possible. You don't want to finish the cycle of CPR and then shock. You want to shock as soon as this shock is available, okay? So you shock, and then there's different monitors with different voltages. A lot of places use the Zoll system. So you want to shock at 120 volts. And then get right back on the chest and start doing CPR for 2 minutes or 5 cycles. After that's done, you want to do a pulse check and a rhythm check. So make sure the person's not pumping on the chest because you won't be able to get an accurate pulse. So stop CPR for a second, do a pulse check and a rhythm check. Then you shock a second time. This time you want to shock at 150. So the second shock is 150, the first shock is 120. After the second shock, now you're in a resistant pulseless mode, so you want to give epi. So remember that epi is given after the second shock. You give epi and you continue the CPR for 2 minutes. Also remember to switch out your compressors every 2 minutes. So this is going to be your CPR switcher, and you give epi. Then you're done your CPR. Right after your CPR 2 minutes, you do pulse check, rhythm check, and you shock if it's indicated, if they're still in the same rhythm. And this time you want to shock at 200. Okay? Now, after your third shock is when you do amiodarone 300. Or, and remember this dose of lidocaine because it's going to come up, it's 1 to 1.5 milligrams per kilogram of lidocaine. So everybody remembers amiodarone 300, but not too many people remember lidocaine, and the test makers know that. So switch your compressors again, continue CPR, and give this drug. CPR's action really is to circulate that drug through your body. So remember, as soon as you're starting the CPR back up again, give whatever drug you have and have it ready. Then you're done your 2 minutes CPR. You already gave the amio lidocaine, you circulated it. Pulse check, rhythm check, still the same. There's no pulse, they're in VFIB or pulseless VTACH. You want to shock them again at 200. Okay? And then you want to give them epi, 1 milligram, and continue your CPR for 2 minutes. So as the person gets right back on the chest, you're going to give that 1 milligram epi. CPR is finished. You give a pulse check, rhythm check, still the same. Shock a 5th time at 200. And now you're going to give amiodarone 150 or lidocaine 0.5 to 0.75. So you're giving half the dose as after the third shock. Okay, so remember that. You're giving epi and amio. You're switching between the two. You start with epi, then amio, then epi, then amio. Epi remains constant at 1 milligram. Amio on the second time goes to 150, and lidocaine on the second time goes to 0.5 to 0.75 milligrams per kilogram. Remember, every time you switch after you shock, every time, remember to switch your CPR people, because every 2 minutes they're supposed to be switched out for effective CPR. So just remember that cycle. After amio 150, for example, then you're going to give epi again during the next cycle, and you're not going to give amiodarone anymore. So after 300 and 150, you're done giving amio. Remember that as well. And a lidocaine max dose maxes out at 3 milligrams per kilogram. So once that dose is maxed out, you don't give it anymore either. Just some other facts here. If the person's in polymorphic VTACH, you want to shock them, and you want to give them 1 to 2 milligrams of magnesium, 1 to 2 grams, of magnesium, and 10 mils of saline over 20 minutes. And if the pregnant woman is already on magnesium and arrests, you want to stop the magnesium, give them calcium chloride or gluconate, and if no ROSC is achieved after 5 minutes, consider giving them a C-section. Next rhythm sets we're going to talk about is PEA and asystole, and we'll run through a similar code set as we did before. So you get them, there's no pulse, the monitor shows PEA, asystole. Start CPR, give O2 and IV access. Now before, in our pulseless VTACH and VFIB, we wanted to shock them as soon as possible. Here we want to give epi as soon as possible. So we give epi 1 milligram. There is no shocking in PEA asystole, okay? You're just doing CPR. So you give epi 1 milligram, you do CPR for 2 minutes, pulse check, rhythm check, you're still doing that before every cycle of CPR. So pulse check, rhythm check, CPR for 2 minutes, make sure you switch your compressors, and then you continue. After your CPR is done, you give another dose of epi for the next round of CPR. So basically how this works is you do CPR, you give epi as soon as it's available, then you'd continue your CPR 2 minutes with your pulse check, rhythm check before every cycle, and you're giving epi every other round. So it's epi, nothing, epi, nothing, epi, nothing for every round of CPR. Alright? In our other case, it was epi, amio, epi, amio. Epi, nothing, right? Because after you've given amio twice, you don't give it anymore. Here, it's going to just be cycles of epi and nothing. Okay? And remember to switch out your compressors. Remember also that because this is a bit more of a downtime rhythm, and you have a little bit extra time because you're not looking at the monitor, you're not shocking, sometimes the instructor will ask you to think of the H's and T's, as well as the sample secondary assessment measures. And those are things like hyperkalemia, those are things like hypotension, hypoventilation, thrombosis, things like that. Things that you can fix during the code that might help alleviate the patient's symptoms. Also remember that if the person has an LVAD or an assist device, this can present as a pseudo PEA. So they'll have electrical activity but no pulse, because people on those machines, the newer ones at least, don't have a pulse. So you want to listen for hums and alarms on those people. You want to assess their perfusion status, and you want to contact the manufacturer. Don't worry, I haven't seen any LVAD cases tested on the ACLS. Now after the arrest, this is also very important. So you want to do a primary assessment, that's ABCDE, airway, make sure they have a patent airway, they can get air in and out, breathing, make sure their oxygenation is okay, circulation, you want to get an ECG, you also want to get a blood pressure, and make sure that their blood pressure is high enough. If not, you want to potentially give them fluids. Then D is kind of a neurological exam. So I forget what D is, but you do a neurological exam, and E is exposure. So for the neurological exam, ask them to grab your fingers, ask them to talk to you. And for exposure, you want to have the patient fully exposed for any injuries and things like that. Then for the post-arrest care for the airway, always make sure you get an ET tube. Usually your patient will not be breathing well. And fluids if they are hypotensive. Remember, you can add pressors to your fluids if their blood pressure is not going up. You can add norepi, epi, or dopamine, and I've included the doses here. And usually, after you get an ECG, the instructor will give you a piece of paper, and most likely it will show a STEMI. Now, the STEMI means you need to prep the patient for the cath lab. If you need to prep them for the cath lab, make sure you get a CBC-CMP, some cardiac enzymes, troponins, before you send them. And also, another very key important thing to know about post-arrest care is targeted temperature management. If the patient finished their arrest, right, they got ROSC, but they're still unresponsive, you can give them targeted temperature management, which is anywhere from 32 to 36 degrees. You're cooling them down. So just make sure for all unresponsive patients after ROSC, you put them in targeted temperature management. Then you can also get things like a head CT and EEG if needed. Glucose management, this is also important with stroke. And make sure you conduct your secondary survey, your H's, T's, and your sample survey if you haven't already had someone do it during the ACLS algorithm. Now, here are the examples of things you need to know about the assessments. There's BLS assessment, primary assessment, and secondary assessment. So if the person is unconscious, you're going to move straight to the BLS assessment. This is your hey, are you awake? Someone activate the code, get an AED naloxone. You're going to check breathing, pulse, and you're going to put the defibrillator on them. Then for the primary assessment, this is either if the patient's conscious or after you finished the BLS assessment. So if the patient's conscious, don't bother with the BLS assessment. Go straight to ABCDE. Okay? And A is airway, B is O2 sat, C is cardiac, so rhythm, BP. Oh, and another thing that's very important, ETCO2. That's a measure of capnography. That's going to be on your sensor for the code, and it's going to basically change colors if their capnography is above 10. So capnography ETCO2 of above 10 means that this CPR is adequate. If it's below that, it's inadequate, so watch out for that on the test. Also, 35 to 40 is a normal ETCO2, so once that jumps to that certain level, you know that you've achieved ROSC. So have that ready after the person has regained their pulse to measure ETCO2 in the post-arrest care. Then D, as we talked about, is neurologic function. You want to check the patient's consciousness, alert, aware, if they know where they are, their pupillary reflexes. E, you want to expose for trauma, bleeds, burns, and then you want to check for H's and T's. Our secondary assessment is done after the primary, and it's done either after the ACLS algorithm is run or during the downtime of the ACLS. Basically, you want to ask family members or if possible the patient themselves their signs and symptoms, their allergies, their medication, their past medical history, last meal, and events prior. So when did this all start? Time of onset is very important here, especially for stroke, because you want to get the last time to normal. And this spells out very conveniently sample, SAMPLE. Okay? STEMI. So if the patient is conscious, do your primary assessment, ABCs, give them aspirin. The dose here is important. So this is 2 to 4 baby aspirin. So a baby aspirin is 81 milligrams. So 2 to 4 would be 162 to 325. And make sure it's non-enteric coated aspirin and it's chewed because it'll allow for faster absorption. Oxygen at 4 liters per minute. And morphine, if you remember the MONA algorithm, M is morphine, O is oxygen, N is nitrates, and A is aspirin. But remember, A is the most important. Aspirin is number 1 in STEMI, okay? Nitro, you give 1 sublingual every 3 to 5 minutes for a max of 3 doses. You don't give nitro if the person is hypotensive, bradycardic, or if they show signs of a right-sided MI, or a recent use of a phosphodiesterase inhibitor like, for example, Viagra. You want to get ECGs for these patients as soon as possible. If they have a STEMI on the ECG, you want to notify the cath lab. Remember, time to PCI for the cath lab should be less than 90 minutes. That's important. And then from the door of the hospital to the cath lab should be 30 minutes. So time from the onset to the PCI should be under 90 minutes. Remember that, it's important. To identify a STEMI, it's going to be very obvious in your drills. The ST elevation is going to be quite pronounced, but just for the formal definition, it's 2 millimeters of elevation in V2 or V3 and 1 millimeter of elevation in all the other leads. And remember, you need at least 2 contiguous leads, so leads that are right beside each other, to diagnose STEMI. You can also diagnose STEMI with a new left bundle branch block, and remember how you see that is in V1 and V6. If anyone remembers the acronym William, L is for left bundle branch block, and W and M kind of mimic the ECG waveforms. So you'll have an R and an R prime in V6. Watch out for that for new left bundle branch blocks. That's how it doesn't always look like a perfect M, but you'll have 2 spikes in the R wave on V6. Then alteplase you can give for STEMI within 12 hours, and you can also consider heparin as an adjunct. For NSTEMIs, you want to consider nitro and heparin, and you want to monitor. Stroke. So stroke's another thing that's tested on the ACLS. It's not tested during the scenarios, but you will get some questions on it in the MCQs. So you want to start with primary assessment, ABCs first, then do the stroke screen. You'll look for facial droop, arm drift, and speech deficits. Establish the last known normal, so whenever they were last seen without having stroke-like symptoms. Then you want to triage them to a stroke center. Now I have the acronyms here for the stroke center listed. The most important one here is Comprehensive Stroke Center. That's going to have everything from the ability to do thrombectomy to alteplase. All of them can give alteplase, but only the last 2 can give thrombectomy treatment. So Comprehensive Stroke Center, and I think TSC is total. PSC is primary stroke center, and TSC is thrombectomy capable stroke center. Yeah. All right. And then for stroke patients, you always want to check a glucose. Remember that it's checked once in the ambulance and also once they've reached the hospital. You want to get an ECG once they've reached the hospital as well. A neuro team to do the neuro exam. Remember, time to CT is 20 minutes. This is an important number. And then time for CT interpretation until CT interpretation once they've reached the hospital is 45 minutes. So 20 minutes and 45 minutes. So as soon as they reach the hospital, they got their neuro exam, they got these basic labs, the ECG. They're going to the CT basically almost immediately just to see if there's bleeding. Because if there's no bleeding, you can go ahead and give alteplase. Alteplase is recommended anytime from 3 to 4.5 hours after the onset of stroke. And remember, you need a BP of less than 185/110 to give alteplase. If this is too high, for example, you can give labetalol, nocardipine, a beta blocker, or a calcium channel blocker to kind of reduce this blood pressure so that they become alteplase eligible. Endovascular therapy, on the other hand, can be given within 24 hours. And it is used usually if alteplase didn't work or if it's contraindicated. And then after they get their therapy, you admit them to ICU. If they have a brain bleed, they go straight to ICU, and you want to monitor vitals, glucose, remember glucose, and their blood pressure should be less than 180 systolic. Also screen them for dysphagia before they leave. Cardioversion. So these can be a little bit confusing. What's the difference between synchronized, unsynchronized, pacing, right? Synchronized cardioversion is done for tachycardia. So the person has unstable tachycardia and a pulse. Unsynchronized cardioversion, there's no pulse plus VT or VFIB. Remember, you don't unsynchronize cardiovert or shock PEA asystole. Pacing is done for unstable bradycardia. This can be transcutaneous, which is second line, and transvenous. Remember, you jump to this for second degree type 2 and type 3 straight away. You don't even try atropine. Then CPR only is done for PA and asystole. And you remember, you alternate Epi, nothing, epi, nothing for those cases. Here's a rapid review of the drugs and their doses. For bradycardia, atropine is the one to know. It's 1 milligram at 3 times. And remember, the T kind of looks like a 1, so that'll help you remember atropine. For VT and pulsus VF, you have epi and amio. Epi is 1 milligram also. I kind of remember the I at the end of epi as 1. And then amio, the M kind of looks like a 3. So remember 300, and then you half it to 150. Also remember lidocaine is 1 to 1.5. So the I in lidocaine looks like a 1 to 1.5, and then later it's 0.5 to 0.75 on the second dose. It's important to remember the lidocaine dose as well. Then for PEA and asystole, it's still epi 1 milligram, just like in this other case. Stable tachy, you want to give adenosine, 6, then 12. It used to be 6, then 12, then 12. Right now it's just 6, and then 12, and then stop. These are usually given within 5 minutes. You can also give antiarrhythmics like amioprocainamide and sotalol as second line for stable tachycardia. And in torsades, remember magnesium of 1 to 2 grams. I haven't seen torsades really tested all that much. Alright, well I hope that was helpful, and I'll see you guys in the next video.